I promise you, I felt the same way once upon a time, many thousands of years ago before the earth had completely cooled. So, my goal is to take you through all of this so that it's less intimidating, because it's not difficult material. For some reason, we just keep insisting on making it sound hard in textbooks, but it's really not that bad. So if you can just take your fear, kind of squish it into a little ball, and just set it to the side for class today. Let's work together and see if we can make you feel more comfortable with it so that you're able to actually think instead of just freeze like a rabbit in the headlights when you have to take a test on it. Because honestly, let's face it, it can't be that hard. Have you met any cardiologists? I hope no one in the room has a cardiologist that's a dear relative that they love and think is extremely brilliant. It's not that bad. Really. There's a lot more complicated stuff. It's essentially plumbing. Did you ever think of plumbers as being the smartest people in the universe? Well, you know, plumbing is complicated and they get paid a lot more than nurses, so I should have gone into plumbing instead. That's a life lesson that's too late for me. But it's the same concept. It's pipes and fluid. That's all it is. It's a lot squishier in people than it is when you run it under a building, but it's exactly the same concept. It's running fluid through pipes, how much pressure it takes to make it go, and how you turn it on and turn it off. That's it. That doesn't sound bad, right? Right? At least you're doing. Everybody else is like, I'm still reserving judgment. About it. And remember, you're welcome to record if you want to, like, bring your recording devices and file them up front. I don't mind. It's okay. Sometimes it's easier when you hear this a second time to let your brain kind of relax and go, oh, that's what she was talking about. Or if you just prefer to pretend this is not actually happening to you, you can dissociate and not pay attention to the rest of the lecture. So what did you learn from your before class reading about perfusion? What do you feel confident that you know? Nobody knows anything? Come on. Shay, you know something. Give me something.
EKG rhythms, because I went to telemetry day.
See? You're way ahead of the game. You're not scared of looking at a rhythm strip. Ha! So you know something. Anybody else know anything? I was like, no. Nothing. I love your honesty, Krista. It's awesome. Surely you must have gleaned at least one fact. No matter how simple. Yes, Russia.
B wave is representing the arterial depolarization.
P waves are the atrial depolarization. The atria fires, it makes a P wave. That's a fact! Yay, rock! Before the end of the day, you're going to be comfortable with all of the little squiggly bits and what they mean. That's the goal, at least. So, if you will just take your panic, ball it up, set it on the floor, listen with an open mind, I think we can make you feel a whole lot better about this. Okay? Okay. You need to do some deep breathing exercises first. Still a lot of tense faces. Just, there you go. Work it out. Work it out. Work it out. My whole family had the stomach bug last week, and the toddler came into the bathroom and was like, we do yoga now. So Folks are in the middle of actively vomiting or having diarrhea, and she's like, no, hands up, stand up. Don't make me force you to do yoga to relax you. I don't want to contemplate what would have happened if someone had actually stood up while having diarrhea, so I'll just go on with the lecture and skip the yoga. What's that thing? See, you do know stuff. God, you give yourself so little credit. The right and the left side of your heart, cleverly named because the right side is on the right and the left side is on the left. Still with me? All right, you're doing a great job. So let's play horrendous choices. You get to choose. You can choose to either have the right side of your heart decide to stop doing its job very well, or the left side of your heart stop doing its job very well. Which one would you pick and tell me why?
I want the right.
Tell me why.
Does it look small on the...
It's a little smaller. I like that. At least you had a reason. Better than just announcing something. Anybody agree or disagree? You hear a lot of mumbling right side. Why are y'all mumbling right?
Still gets wrong, it gets the right a little bit, but the right left side fails, then it doesn't get caught.
It all comes down to the job that the sides do. The right side of your heart has it easy. If you wanted to be part of the heart, you can't get any easier than being the right atrium. Because all you have to do is take blood and let it fall downstairs to the right ventricle. That's what happens. When the valve opens between the atrium and ventricle, blood drops. Most of the work is done by gravity. The only reason that our atria even contract at all is because sometimes people are upside down. And then you wouldn't have blood go anywhere if you didn't have some squeeze. But the squeeze of the atria, called the atrial kick, only adds about 15% more blood movement. We open the floodgate, and the blood falls. Okay. Man, that's not much work at all, right? You just let it go from upstairs to downstairs. That's pretty easy. What does your right ventricle have to do with it then? And where are your lungs in relationship to your heart? Next door. So your right ventricle has to go. You don't have to move it far. Literally, next door. A few inches. So, does your right ventricle have to squeeze very hard to make that happen? No! Seriously, we're moving fluid like this far. So, a nudge will do you. So, the pressures on the right side of the heart are really low compared to the pressure on the left side of the heart. What's the left side of your heart have to do?
Get the rest of your body.
We have to shoot this blood from the left ventricle all the way up to the top of your head and all the way down to your toes. Is that more difficult than? A lot more. So your left ventricle is a lot more muscular. The cavity itself has a stronger muscle because it has to squeeze a lot harder and generate a lot more force to shove that blood all the way down to everything. Make sense? So your left heart works a lot harder than your right heart. Oh. See why I said the easiest job in the world is being the right atrium? You can slack off and not even contract, and you're still going to be alive. Would you die if neither of your atria did their job? They didn't contract at all? Nope. Sure wouldn't. You might have a little bit less cardiac output. What's cardiac output? Let's define that before we go any further.
The amount of blood ejected by the left ventricle per minute.
Okay. So cardiac output tells us how much blood are we shoving from the heart to everywhere else in a single minute. How much oxygenated blood can we move in 1 minute? And for a normal adult, how much blood do you think your heart moves in a minute? Take a volume guess. Soda bottles worth? 2? How much do you think?
1
Liter.
A lot more work than you think. For an adult, 4 to 6 liters of blood a minute is a normal cardiac output. That's a lot. When you consider removing it from a chamber, that's roughly this big. That's a lot of work. Your left ventricle is the underappreciated, overworked hero of this situation. So, do you think that the pressures on the left side of the heart are higher than the right side? Yeah, about 3 times as high on average. So, moral of the story is, if something happens to the left side of your heart, will you die fast or slow?
Fast.
Fast. If something happens to the right side of your heart, will you die fast or slow?
Slow.
Slow. It'll get you in the end, but it'll take longer. Everybody with me so far? This doesn't seem so bad, does it? It's pretty straightforward. I kind of like this. All right. So, do I think that you will need to know all of the vessels and where they come from? No. Do I think that you need to know which valves lie between which chambers? Yes. So I would put some memorization work in, learning which valves are where. So if we want blood to escape the heart, what valve does it go out? What vessel is it going through as it exits the heart? What's the vessel that takes blood from your left heart to the rest of your body? The aorta. Okay. So is your aorta a high or a low pressure vessel? High. Arteries are extremely elastic. They have the capability to stretch like a pair of Ted hose and contract as needed. Remember that. That's going to be important later when we talk about fixing things that go wrong. Veins, on the other hand, are kind of flabby. They don't have the musculature that lets them tighten up the way that arteries do. Make sense? Look at that. Okay.
Thanks, Joanne.
When we send blood from the right heart to the lungs, does it go through an artery or a vein? We're sending deoxygenated blood through an artery and coming back oxygenated through a vein. It's the only time in the body that your veins are handling oxygenated rather than deoxygenated blood. We use the artery and its muscle to push, and it's going to passively return. Make sense? Everything else, all of the pumping oxygenated blood for everything else is handled by the arterial system. When we have arteries, do they break into smaller parts at some point? What are they called? Arterioles. And do those get smaller? What do we get to? Capillary bed. We have tiny arterioles that go into the capillary bed. So, distal perfusion is fingers and toes. If your patient has a weak left heart, where are you going to see signs of poor perfusion first? Fingers or toes? Toes, why? Because they're farther away. Yeah. This is one of the reasons that when you do a full assessment on a patient, we don't want you just to check a pulse at the wrist and the skin temperature on the hands. We want you to look at their feet and check their pulses, because they may have a chronic issue with arterial insufficiency, and the skin will be kind of waxy and cold. You may have a hard time finding pulses. Pulses on feet are tricky. So if you feel like you struggle to find pulses on people's feet, it's okay. That's normal for people who are just learning to do it. It takes some time to figure out where to stick your finger to get a pulse. What do you do if you can't find a pulse on a patient and they look pretty healthy and you're pretty dang sure they've got a pulse in their foot? We can use a Doppler, and that makes it easier, because you just kind of run, it's like a little metal detector. So you just scan for treasure. Treasure in this case would be an artery. You find it. What do you do then?
Mark it.
You mark it so that you don't struggle the next time. So you take either a medical marker or a ballpoint pen, depending on your personality, and you make an X where you found it, so that the next time you need to check it, and the next shift, you know where it is. This is also a good way to know if the people on the opposite shift are actually bathing your patient at any point, because if your mark is there when you leave on a Friday and you come back 3 days later and that mark is still bright and clear, it's bath time, right? Okay. Still comfortable so far? Everybody's feeling panicked? All right. Do you need to know the pressures in each chamber? Not as a second semester student. But I have this slide just to show you the differences in the pressures between the sides of the heart. So if we're looking at the right side of the heart, high pressure is 30 over 12. If your blood pressure was 30 over 12 for your whole body, how would you feel? Dead. Dead, basically. That's horrible. But that's all the force it takes to shoot blood next door to the lungs. Looking at the left heart, we're going to see pressures that reflect overall blood pressure as it exits. So up to 140 over 90 would be considered the high end of our normal limits. Still with me? Okay. We have to know where the orders come from that tells your heart to do something. Because we want it to beat, and we want it to be organized. It's like a marching band. You have to have somebody giving direction, or it's chaos and there's just tubas everywhere and it's not very pretty. So where does your heart normally take its orders from? Up top, the SA node, up in the right atrium. So up at the top of the heart, this is our normal pacemaker. How fast does the SA node tell your heart to beat? 60 to 80 is pretty normal for an adult. Remember, the numbers are different for kids. Oh yeah. Do I need to know that? Yeah, you should know the ranges that are normal for children. Man, does that mean that if your SA node quits, takes a vacation, goes to Jamaica to get married, that you die? No, because there would be a lot of dead people. We have redundancy systems built in for backup. So if your SA node poops out, then we move down to the muscle between the atrium and the ventricle, where we have another spot that can organize at least the ventricular beats, and what's called the AV node. It's between the atrium and the ventricle. Gosh, I wonder how they came up with the name atrioventricular node. You think you can remember where this one is? I sincerely hope so. So if our AD node poops out, and this gives us a heart rate around 60, 50 to 60. Not awesome, but certainly good enough to get by. If it poops out, does that mean we drop dead? Not yet! Not yet, but wait, there's more. So who takes over next? We can use the bundle branches. They're going to give us a much slower rate, 40-ish. But at least it's something. What happens when the bundle branches start to wuss out? We can get some contractility, if we're lucky, from the Purkinje fibers. And this is going to be a really, really, really funny looking rhythm strip called an idioventricular rhythm. And this will buy you 20 to 30, which isn't enough to keep you alive for long, but it's enough for us to do something about it. The moral of the story in cardiology is you fix something when the patient is symptomatic. What would be symptoms of a very low heart rate? No energy, cyanosis, oh, low pulse. If you can find a peripheral pulse, you're really lucky because basically you could probably only be able to get carotids, if anything. Because as the heart rate drops, we stop perfusing everything. First we say limbs, you're gone. Then we say gut, liver, forget about you. Then it's kidneys. Then we're down to just doing lungs, brain, heart. Lungs, brain, heart. So as that heart rate gets slower and slower and slower, what happens to your patient's mental status? It's going downhill. With a heart rate of 20 to 30, your patient's probably not conscious. Which is good because we're going to have to do some ouchy things to make their heart speed back up, right? So what do we do if your heart rate's too slow and we want to speed it up? Okay, hold that thought and we'll come back to it. Not defibrillate. We will talk about that. We can give them a procontractility agent like epinephrine. Atropine speeds up the heart rate. Or we could just use electricity. Not defibrillation, but pacemaking. What does a pacemaker do? It becomes the boss. It starts telling the heart when to contract. If you have a patient who acutely develops an idioventricular rhythm or any heart rate that's too slow for them to not be symptomatic, we can do pacing through the skin. We put the patches on. Most defibrillation pads are also capable of doing transcutaneous pacemaking. So what we do is we use the machine that we use to defibrillate to send zap, zap, zap electricity through the skin to the heart every time we want it to beat. Yes, ma'am?
My grandpa had to do that before, because he was on blood thinners and
Uh-huh.
he couldn't put in a pacemaker. So they gave him something that looked kind of like a bra.
Yeah.
That he would call his bra. And it had on one side here and on the back side there, these little pads.
Yep.
And it was, if his heart rate went too low, it would shock him.
And that's an important thing about pacemakers, is we can set them. Do we want them to be on all the time, no matter what? Do we want this patient, because sometimes we do. Sometimes we say, I want this patient to have 70 beats per minute, and I want it to run all the time. We can set it to be what's called a demand pacemaker, meaning it's listening, and if the heart rate drops below a threshold, and we pick the number under 60, then it's gonna start zapping you until your heart rate comes back up to where we want it to be. So what's the downside to transcutaneous pacing other than having to wear an unattractive medical bra? Why don't you see jillions of people wandering around wearing these? What did your grandpa think about the whole thing?
I didn't like it.
Tell us why.
It was uncomfortable.
Yeah, sure shooting.
When he
How
laid
come?
down- When he laid down, the one in the back was kind of poking inside.
Every time that you need it to make your heart beat, it sends electricity and it's got to penetrate all the fat, all the muscle to get into your heart. So we have to use more power to do it from the outside than we would from the inside. And the longer that you have the transcutaneous pacer pads on, the more sore your skin gets, and eventually you start to develop electrical burns. Oh, yeah. So a person who's being paced, after a while, you watch the monitor, ow, ow, ow. Doesn't feel good. So it's not a permanent solution, but it's a short-term solution. If we have an interventional cardiologist in the house, we can go one step between transcutaneous and implanted pacemakers. Do you know what that is? We can do one that we drop down the jugular. So we can do a pacemaker where we place the wires down through the patient's neck to their heart. Transvenous pacing. While it doesn't give you the burns on your chest, you've got wires inserted through your neck that control your heart rate. So what would happen if your patient was doing a lot of head movement in the bed? Those wires are going to be going up and down and around. So we have to get the patient basically immobile for that to work. Because we can't let the electrical wires touch just anywhere in the heart. Is that the wrong place? You may cause the heart to go into a fibrillatory rhythm, and that's one of the few lethal rhythms that you can have. So you want the wires just to touch the atrium, not the ventricle. So your patient is going to have to be very still. And sometimes we even use sandbags to position them so they can't turn their neck inadvertently in their sleep. Also not comfortable. But, just like her grandfather, if we need to put in a permanent pacemaker, we prefer that you not be heavily anticoagulated, because you're going to bleed out. We can do an implanted pacemaker though. It's an outpatient procedure for most patients. They tunnel a little pocket to put it in, slide it in there, run the wires down, and actually kind of tack them in place on the heart so that they don't roam around. When you get a pacemaker implanted, is that pacemaker going to last forever? Why not? Needs a new battery. Like anything else electric, there's only so long that battery's going to last. There's a trade-off between how strong the battery is and how long we can make it last and how bulky it is. Because nobody wants to have something the size of a fist sticking up out of their chest wall. People like something low profile and it's not going to rub on your clothes, it's not going to catch on your seatbelt. We want them to be as slim and flat as possible for patient comfort. Yes, ma'am.
So those first two, they're just temporary fixes.
They are temporary, and those are, you are in the hospital, and you are on complete bed rest, and I have got an eye on you at all times. No freedom, no mobility. If you've got a stable enough rhythm where you're just occasionally dipping below where we want you to, we can turn you loose with one of the outpatient ones. But you have to be pretty close to stable for us to do that. Most of the time we just park you in the hospital for a few days while we wait for you to be back with your INR low enough that we can take you to surgery. So, pacemakers last as long as they're battery. We like to replace them before the battery runs out, which means we schedule them. They usually last between 5 and 7 years, but just like any other electrical device, the more you use it, the faster you drain the battery. So for people who only occasionally trigger the pacemaker to work, the battery lasts longer. For someone who is 100% paced all the time, that battery life is going to be shorter. The other thing that wears out is the wires. They tend to get fragile, they weaken. The movement causes microflexion, and they may break. And if they break, they can pierce the wall of your heart. And if your heart gets pierced while it's still in the pericardial sac, the pericardial sac fills up with blood, which slowly squashes the heart until it can't fill up and beat anymore, and it kills you. And that's called a pericardial tamponade. Sounds like fun, right? How do we fix that? Surgery. We poke a hole in the pericardial sac and we suck all the blood out. And then, just like a miracle, your heart reinflates and can start pumping again. Yay! We just have to know that's what's wrong so that we can actually fix it. Comfortable with conduction so far? Yes?
What was that thing you said? What was it called again? Pericardial.
Tamponade?
You need to know that.
I would think it would be prudent to. It may not be on this unit test, but at some point between now and your licensure, you will be asked about it. Now we get to the part that makes everybody wet their pants. What am I supposed to do with all these lines? This is just a hot mess. Dr. B, I don't know what to do. I don't like it. I look at it and it makes me sad. And I want it to go away. Can we make it go away? No. So I guess we're going to have to learn about it. So, everything that you see here is a reflection of electrical activity. Not of contraction, but of electrical activity. Does this tell us the patient's heart is actually beating? It tells us that the electricity is being sent appropriately to the atria and the ventricles. But a rhythm strip doesn't tell us if they're actually doing their job. I don't like that very much. But it's possible. It's called PEA, pulseless electrical activity. It's not very common, but it can happen. So just because you have this on a monitor, it doesn't mean your patient's heart is beating. You gotta go and verify it. If you go in the room and your patient says, "Hey, what's up?" Their heart is beating. It's cool. Let's break down what makes the different electrical marks happen. All right, you ready? What's the weakest part of your heart? The atria. So when the atria squeeze, we have a little bump that shows us depolarization, which is a big fancy word for firing. The electricity goes boom, and your atria go. Did it take a lot of power to make that happen? No, it's a little bitty lump, right? But that's expected because, remember, our atria don't do a lot of work. They give us a gentle nudge to help gravity. The next thing that we see happening is a whole lot of power. What do you think that's about? Ah, your ventricles. Depolarization of the ventricles. The big, strong part of your heart needs a lot more electricity to make it do its job. No, that's really common sense, actually. So far, this is very logical. Now we have a little bump here at the end called a T wave. What's that about? Ventricular repolarization. This is when your ventricles are like, oh, shake it out, man, and get ready for the next time. Okay, we're good. Get loose, get loose. We're good. Get loose. Where's the way for atrial repolarization? Yeah, it's a trick. You can't see it because your atria are repolarized somewhere right around here. And it's hidden by the QRS complex of your ventricles firing. If your patient had an incredibly slow sinus bradyrhythm, we might have all of this stretched out enough that you would see the tiny wave of atrial repolarization. But your patient would have a heart rate around 20. So, it's cool that we can't see the relaxation part of the atria's job. Ventricles fire, ventricles relax. Everybody good with that? Okay. Remember that the electricity goes from the atria to the ventricle, right? That's the path it takes from here to here. Because we want this chamber of the heart to squeeze and push blood down into this one so that when the ventricle contracts, there's something there to push out, right? Okay, great. So, by looking at the distance between your P wave and your QRS complex, we know how long it's taking for the electrical signal to go from your atria down to your ventricle. It shouldn't be greater than 0.12 seconds. Your PR interval should be 0.12 seconds or less. You probably won't need to know that number this semester, but you will in fourth. The longer the gap between your P and your R tells us there's a delay in conduction from the atria to the ventricles. Is that good? Mm-mm. We don't want that. We want these things to be very nicely coordinated, everything on a tight schedule. Squeeze, squeeze, we move on. So if you know there's a delay in conduction, that tells you have some sort of underlying cardiac issue. Okay, cool, I gotcha. Does this part make sense so far? Okay, I'm starting to look worried. So, we need to have 3 things to have a normal sinus rhythm. We need to have a P wave before every QRS. We need to have a QRS. We need to have a T wave at the end. So what we do when we're deciding if a rhythm is a sinus rhythm or not, what that means is that we have atrial action followed by ventricular action followed by ventricular relaxation. So the first thing we do is, ooh, there's some spiky things. What are those called? QRS complex. We look for a little lump in front of every QRS complex. Okay, so I got one here, I got one here, I got one here, 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 here. So there's a P wave for every QRS. And your P waves should look exactly the same each time. I won't bother you with details about what happens when they aren't. But for a sinus rhythm, every P wave looks just like the others. Do we have identical P waves in front of every QRS here? Yes. Yes, awesome, we do. Do we have equal looking QRSs? Yeah, they're about the same. That's good. That's awesome. Do we have a T wave after every QRS? Yep. Yeah, we sure do. So this is a sinus rhythm. That's normal. As a first day grad, you have to know completely normal and holy baby Jesus, I need help. Okay? So this is completely normal. And this is a 6-second strip. So let's count and get a rough estimate of how fast this heart is going. So we're going to count R to R intervals, meaning the space between these. So we've got 1, 2, 3, 4, 5, 6, 7. We have 7 R to R intervals, meaning this patient's heart rate is around 70. We have a little extra action over here, so we're probably 74-ish, just looking at it. But it gives us a quick estimate of whether the patient has a slow heart rate, a normal heart rate, or a fast heart rate. Everybody good with that? Starting to see some really worried faces though. Okay. So let's look at this rhythm and decide what you think about it. Do we have a P in front of every QRS?
Yes.
Yeah, we do. They pretty much look the same. Our QRSs pretty much look the same. We got a T wave after each of our QRSs. And now let's decide how fast this heart is going. So we've got 1, 2, 3, and 3/4. So this patient's heart rate is around 35. This is a sinus bradycardia. All of the parts of a normal rhythm are here. You've got your P wave in front of every QRS. You've got your T behind it. It's just very slow. When would we treat this rhythm? When would we do something about it? When would we have to intervene? When they're symptomatic. So if your patient is someone who's a triathlete or an ultra marathoner, I've seen patients whose sleeping heart rate is in the high 30s, low 40s. It's just them. Their hearts are that muscular and that efficient that at rest, that's all they need. If they're not symptomatic, leave it alone. But if your patient is cold, clammy, dizzy, no pulses in the extremities, we should do something about it. What should we do? What are our options? Remember, I already named them. Atropine, epinephrine. Ow! Ow! Oh, a pacemaker! There we go! Awesome! Awesome sauce. Remember when we talked about a really funny looking rhythm, an idioventricular rhythm? Okay. So here we're going along. Do we have a P wave? No. Do we have a QRS? Yeah. We've got an inverted or upside down T wave. How fast is this going? We've got 1, 2, 3, close to 4. So around 40 beats per minute. But we know there's no atrial involvement because we've got no P waves. That means the atria have just bonked off and they're taking a nap. Okay. Fair enough. Do you notice how this is different than a sinus bradycardia? P waves, no P waves. P waves, no P waves. P waves, no P waves. Good? Oops. Forwards. Let's look at this one. Do we have P waves? in front of our QRSs?
Yes.
Oh, we do. Do our QRSs look roughly the same? Mm-hmm. Roughly the same distance apart. We like that. We like them to be pretty close to equal. Do we have a T wave after each one?
Yes.
Wow, we sure do. So let's count and see how fast this is. So we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 12 R-to-R intervals. This is around 120 beats per minute. And you don't have to be a tele expert to look at it and recognize that this looks like a much faster heartbeat than this, right? So even without counting, you can glance at it, and just by how far apart things are spaced, you can tell the difference between Brady and Tacky, right? What happens when everything is so fast that it's all run together, and you can't tell if there's really a P wave here or if that's just part of the T wave?
Assume it's not there.
The only way to find out for sure if there's really a P wave is to slow this heart rate down so that we can see. And this particular rhythm is called PSVT. So it's a ventricular tachycardia, but it's perfusing. That means we're still moving blood out of the heart, okay? Let's count how fast this one is roughly. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. So around 200 beats per minute. So let's ask ourselves the question. How would a patient feel with a heart rate of about 200? Tired. One word for it. Is this a rhythm that would be symptomatic or asymptomatic? Symptomatic. How come? I mean, we're beating a lot. We're doing a lot of work here. So what's the problem? Why is it not a good thing? You increase the amount of cardiac output as you increase your heart rate. Cardiac output is heart rate times stroke volume, the amount of blood we squeeze out each time the heart beats. And we reach a point on the curve where we start to actually have diminishing returns. But the faster the heart rate goes, the lower our cardiac output gets, because we have to give enough time for blood to go from the atria to the ventricle so that it can be squeezed out to somewhere. When our heart is beating as fast as PSVT, we don't move much blood. So we're just moving drips at a time. So our cardiac output is falling. And these patients have the same kind of symptoms that you would see in someone with a very low heart rate. Dizzy, lightheaded, pass out, feeble, thready pulses. They're not moving much blood. So, they're symptomatic. What do we have to do about it? We gotta slow it down. How are we gonna make that happen? Say louder. We could give a cardizem drip. As long as we're positive what we're dealing with is PSVT, then cardizem is safe. If we're not sure, and it could be a different type of arrhythmia that you don't need to know right now, then that could potentially kill them. But if we're sure it's PSVT, then yeah, we can use a cardizem drip. Usually the first thing we do is to try to slow it down for a little bit to be sure of what we're dealing with. How can we make that happen?
Medication.
Yes, Linda. Oh, which medication? Well, beta blockers do slow heart rates, but that would take us a while. We have something that we use quickly. Well, we give them oxygen because we want them to, to oxygenate as much as possible what little blood is moving out. We use adenosine. Adenosine is a medication that we give as a very, very rapid IV push. So you want a large bore IV as close to the patient's heart as possible. So left AC is ideal. I would like it to be an 18. That would make me happy. We draw up our adenosine. We start with 6 milligrams. And we give it as a very rapid IV push. And we follow it with a fluid bolus. So it's easiest if you have 2 nurses do it. One that's at the closest Y site that pushes the adenosine, and one at the Y site right above that pushes immediately a 10 mil flush. Because what we want to do is to shove that adenosine into the heart really fast so it can temporarily slow the heart down. Our goal is, my slide. Do I have that slide? Is to, what do I do? Take the heart rate and slow it to nothing for a moment. It's like doing a hard reboot on a computer. We don't know what's wrong, it won't work, so we're just gonna unplug it and plug it back in and see if that works. So giving adenosine as a very rapid IV push slows the heart rate to a standstill. And your patient feels this. So they're awake and they literally feel their heart stop beating in their chest. And there's an indescribable look of horror on their faces every time they happen. Almost always, 99.9% of the time, heart rate starts back up. If we're very lucky, it starts back up in a normal sinus rhythm. Yay. Sometimes 6 milligrams isn't enough. In that case, we give them 12 milligrams, exactly the same way we did the first dose. If that doesn't work, there's 2 different modes that folks are using now. We used to just give a second dose of 12, but now some people choose to use 18 instead. So, once we hit 3 doses of adenosine, regardless of whether the third is 12 or 18, it's not going to work. So we're going to have to try to overdrive pace the heart. Meaning we're going to use so much electricity with transcutaneous or transvenous pacing that we're overriding the heart's own electrical signals and bossing the heart into beating as fast as we want it to, not how fast the heart wants to. Make sense? You guys want to take a break really quick? You're starting to look really miserable, fidgety, pale, distressed. Carbohydrates and some fluids, and optimistically a chance to go to the potty. So, when you look at this rhythm, what do you notice about it?
It's different.
It's different. It's definitely not normal, right? And these are goals. These are living our best life as first day grads. It doesn't look like the other things we looked at. What looks so different about it? Yeah, it's kind of hard to tell what anything is except for, it seems to be a QRS complex. We don't have a baseline in between each beat. We just kind of lump straight from one into the next one, and that's unusual. I'm not really sure if this little divot can be considered a T wave or not. Not really sure if that little lump can be considered a P wave or not. Yeah, they're not. So what I have are essentially wide. Notice how far apart they are. Instead of being little skinny lines, like a QRS complex normally is. We've got space in between. And that, we don't like that. That's not good. That's called a widened QRS complex. That's a sign that there's a problem with delay in the electrical conduction through the ventricle itself. So the ventricle's getting slow power. Do we want the part of our heart that works the hardest to have a conduction delay? And no, not. So what we see is just the ventricular part of electrical activity, right? No baseline, no atrial, anything we can see. Is this a fast or a slow rhythm?
Fast.
Fast. So congratulations, you've just identified a lethal arrhythmia called ventricular tachycardia. All you see is the ventricular part, the QRS, and it's fast. And that's how they came up with the name. Yay! What would a patient with this rhythm feel like? Is this a symptomatic or an asymptomatic rhythm? Symptomatic. Can you have VTAC, as it's popularly referred to, and have a pulse? Yes, temporarily. Very temporarily. Why won't you have a pulse for very long? Because you're not. What happened?
My answer for everything today.
Remember, now we've got zero coordination going on between the top and the bottom. All we're seeing is the electrical activity for the bottom. So we're not getting any of the benefit of the atrial kick. We're only getting what gravity drops to the ventricles. And it's a fast enough rhythm that the ventricles aren't getting a good chance to refill in between each time they beat. So there's not a lot of blood actually being moved. Yes, you can have a pulse with this for a short period of time. But quickly you get to where you're just not moving much fluid. You're running the pump dry. And if the pump's not moving blood, you don't have a pulse. So when we look at VTAC, this is a fairly slow example because I wanted you to be able to see how wide the QRS complexes get. We're usually looking at a heart rate 200 to 260, which means we're not moving blood to speak of. This is a rhythm that requires immediate attention. Now, let me introduce to you the concept of trickery. Just because you see this on the monitor, it does not necessarily mean that that is truly the patient's rhythm. How could that be true?
Patient, not the monitor.
Okay, you always check the patient and not the monitor. People who have been in the hospital for a while and want attention know that the easiest way to get everyone in your room is not to ring the call light, but to take your fingers and tap like this on one of the leads on your chest, which produces an artifact that looks like that. And it makes the monitor start boom, 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 dinging and alarming, and everybody comes running in, and the patient says, "I'd like another ginger ale." That is not real VTAC. But the only way to know for sure is to go and assess the patient. So, on a test question, if you have a rhythm like this, what's the first thing you should do? Assess the patient. If this is truly their rhythm, then we need to treat it. And this is a time that we would talk about defibrillation. I want you to keep two things separate in your mind. So you ready to build a wall? Okay. Patients who have rhythms that we hate with no pulse get defibrillated. D for dead goes with D for defibrillation. If the patient has a rhythm we hate, but they still have a pulse, then we use less energy to shock the heart, and it's called cardioversion. So you've got that wall built nice and strong. Pulseless dead people get high electricity defibrillation. People with nasty rhythms but a pulse get cardioversion. And there are many other unfortunate rhythms besides this that have a pulse and get cardioversion. Okay? But as long as they've got a pulse, it's called cardioversion. Once they lose the pulse, we turn up the power, and it's defibrillation. Got that straight? This is invariably going to be a test question at some point between now and your exit from school. All right. Now let's look at this. Does this look like a friendly rhythm? Does it look consistent from blip to blip? It's kind of all over the place, right? It's little, it's big, it's scraggly. If you're a patient and you want attention and you want to make this rhythm as artifact, you scratch your lead instead of tapping it. So this is chaotic, completely disorganized electrical activity. It's called ventricular fibrillation. And all fibrillation means is wiggling. So instead of going swoosh, swoosh, the muscles of the ventricle are going. How much blood am I going to move by going? None. This is a pulseless rhythm. There is no functional exit of blood from the heart. It's just wiggling. And if you've got a patient in the middle of cardiac surgery and got their heart exposed and their heart starts to fibrillate, it truly is just like rides, like it's full of bones. If you want to YouTube it tonight, you can watch plenty of videos out there. They're fascinating. It kind of looks like you ever seen those, the weasel balls? It's a little ball that goes in a circle with like a furry tail attached to it. It just looks like there's a weasel ball in there, just going nuts. That's for your free time between 11:27 and 11:29 tonight. So this is invariably lethal if not treated. How do we treat it? Defibrillation! Because they don't have a pulse. Now, on the ranking scale of really crappy rhythms to have, this is better than that because at least this is organized. Notice how it looks the same from funky beat to funky beat. There's a little bit of organization here. The more organization you have, the quicker you're going to get them back to where you want them to be. The more chaos you have, the harder it is to get something back to behaving. So this is like the mosh pit. They're not gonna shine up real quick with bows and smiles and stand in rows. This we defibrillate. But this is still better than this. What is this?
We're dead.
This is dead. Or the patients pulled off all their leads and stuck them on the bed rail. So once again, you must always check your patient. If they ask you, why is everyone running in my room? Clearly they are not in asystole. This is a pulseless, apneic rhythm. What do we do about asystole? Who said CPR? Rockstar. We do not defibrillate asystole. We do CPR. Why? Because the whole goal of using electricity in defibrillation is to kind of slap the naughty heart into putting its electricity back to the way we want. If you got no electricity, slapping it's not going to help. So we do not shock asystole. We don't. Now, sometimes you'll work with a doctor who will say, well, I mean, maybe it's extremely fine VFib, because this VFib goes on, progressively. It goes from being tall like this to getting to where what you're looking at is really short wrinkles instead of big wrinkles. So sometimes you'll have a doctor that says, well, maybe it's really fine VFib, let's shock it. Well, I'm going to be honest with you. They're dead. You can't actually kill a dead person. The worst thing that's going to happen is that you had a chance to reorganize a marginal amount of electricity and you boo-booed. But again, they were dead, so it's okay. Don't beat yourself up about it. If they say defibrillate, you don't have to get into a fist fight over the dead person in front of you. Shrug your shoulders and push the button. But the test answer is that we do not defibrillate asystole. We begin CPR and medications. And we give medications like epinephrine, lidocaine, atropine to try to stimulate the heart to have a little electricity, a little glimmer, a flicker of hope. And as soon as we see that flicker of electrical activity, then we defibrillate them. Now, if the whole time we're watching the monitor to try to decide if we should defibrillate or not, somebody's doing CPR, quality CPR is going to give you a rhythm that looks a lot like that. Oh. What do you know? So if you want to know if you're doing it well, look at the monitor. It's not going to be quite as pretty as that, but you should be getting a nice peak for every time you give a chest compression. You've all been forced to take CPR recently, or at least pay someone to lie on your behalf and give you a card. So how many times per minute do we do chest compressions? Oh, 100. Every 3 to 5 years, the American Heart Association changes something in the CPR guidelines. 25 years in, I'm firmly convinced it's merely so they can sell a new set of books every 3 to 5 years. But currently, 100 times a minute, we do chest compressions for CPR. How hard do we push on an adult? How many of you own a bathroom scale? Okay, so this is your homework for tonight at 11:30 p.m. as soon as you finish Googling videos of ventricular fibrillation. Get your scale out, kneel on the floor before it, take your hands, push until you register 25 pounds on the scale. Because that's how much pressure you should be using every time you provide a compression. You need to be pushing the chest 1.5 to 2 inches down. And for an adult, that takes about 25 pounds of force. It's a lot. You'd be surprised at how hard you actually have to push to make the scale register 25 pounds. And do it 100 times a minute for the length of the code. I've worked codes that have gone more than an hour. So, we have to switch off pretty regularly. Because if you ain't sweating, you ain't doing it right. Easiest job in the universe, airway management. Second easiest job in the universe, I'll be the recorder. Sit in the corner with your clipboard. Epi in. Atropine in. Shot. Have a little snack, a little beverage with you as you stay out of the way and let everybody else work. So I would call dibs on one of those 2 jobs if I were you. Keeps you from getting all sweaty. Otherwise, you may end up kneeling in the bed with the patient. The bigger the patient is, the harder it is to make that chest go down a couple inches. Yeah.
We had one that was like 450 pounds.
Yeah, you kind of have to sit on them and bounce at that point because that's about all you can do.
You're like on top of the patient.
Yes, you're riding them like Seabiscuit. You're up there just giving it all you got. You just hope that your best is good enough. It gets very distressing. Flip side of that is when you have teeny tiny, skinny, fragile old people and you push and you hear the ribs break and the crunch every time you give a compression and you feel the crepitus as you push. That's not fun either. But so it goes. Better to be alive with broken ribs than dead with an intact rib cage. So they say. Having never personally been in either situation, I cannot comment from my standpoint. Do you feel more comfortable with rhythms? These are the things you must know as a first aid graduate. Normal sinus rhythm, the tach, the fib, asystole. Because 3 of those require immediate emergency help. Everything else in between, you have a couple minutes to go grab somebody and go, hey, I don't know what the heck I'm seeing on this monitor. Can you put that? But the ones that are mostly dead, I need you to hit the call light now. Make sense? Let's see if I've got a B-fib under somewhere. Heart blocks, you'll learn more about in 4th semester. It's just a delay in conduction from place to place. So leave that thought in your head. A heart block means that there's something slowing the electricity from the atria to the ventricles. You cool with that? Awesome. Something I had somewhere in here. Okay, here we go. One more thing I wanted to show you. This is the greatest hits rhythm of little old people. So let's look at it and decide what we've got going on. Do we have QRS complexes that are more or less the same height? Yes. more or less. Are they evenly spaced? No, not this time. Do we have a P wave in front of every QRS? Do they look the same? No, we got a lot of weirdness, right? And what's all this lumpy stuff in between? So this rhythm is called atrial fibrillation. And it's an irregular rhythm, meaning that it's irregular because it's not a normal sinus. And the space between QRSs is different from beat to beat. This is what happens when just your atria go instead of. So we lose the atrial kick. We get about 15% less blood moved down to the ventricle every time we have a heartbeat. And this is a perfectly livable rhythm. Many elderly patients have atrial fibrillation and do not know that they have it because it's frequently asymptomatic. When it becomes symptomatic, we do something about it. The problem with atrial fibrillation is having your atria just go all the time leaves blood pooled, it doesn't get squooshed down, and the blood can begin to form clots against the walls of the chamber itself. So if we were to cardiovert, this is a rhythm we can cardiovert to fix. If we were to cardiovert this, and the patient had developed some clots lining the walls of the atria, we would immediately squeeze them to the ventricle, to the lungs, and to the brain, causing a pulmonary embolus and or a stroke. So, the only time that we cardiovert atrial fibrillation immediately is when they've been in the hospital and we've seen their rhythm change from something more normal to atrial fibrillation. So if it's happened in the last couple days, okay, that hasn't been long enough for them to have built up a lining of clots on the walls of the atria. We can go ahead and cardiovert them. But if they come in and they're not feeling well, they're tired, lethargic, a little sluggish, not feeling great, and we find surprise AFib and have no idea how long it's been there, we can't cardiovert them right away. First, we have to put them on blood thinners and do an echocardiogram to make sure that we don't see any clots lining the atria. As long as there's no clots there, we can cardiovert them. If there are clots there, we have to wait for those clots to break down and for the blood thinner to keep new ones from forming, and then we can cardiovert them. And for this, we can use medication or electricity to cardiovert them. So just hold on to that knowledge for future times. But atrial fibrillation is very common in the elderly. Remember, your atria don't really have to do a lot. They've got the easiest job in the whole joint. So it doesn't usually create a major amount of symptoms for patients. That's why it can go unnoticed for a while. Make sense? Okay. What questions do you have about EKGs and rhythms at this point? there's a couple more things I want to point out to you if I've got. I don't know if I have the slide that I want. By the way, if this is just for a bonus, if your patient's in atrial fibrillation and we cardiobirth them with electricity, you'll see a square waveform. Notice how the top is squared off. This is where we push the button and zap them. So, zap! And then, look! Awesome! I got a P wave, a QRS, a T, a V wave, a QRS. So that's an awesome outcome from an electrical cardioversion. Yes, my dear?
How can you tell the difference from an inverted T wave and a U wave? Like, what would like help me distinguish those?
Usually an inverted T wave is larger than a U wave. But again, that's above the level of where you should be in second semester. I wouldn't give myself too much stress or heartburn over it. I love the fact that you want to take it to the next level, but I try not to introduce too much that leaves people sad and confused on test day when they go, oh, wait, this is a what? Oh, man. Don't anticipate that appearing on the exam for second semester. But we can hang out after class and chat it up. Calm down. There's a difference between a rhythm strip and an EKG. And that, I'm pretty sure backwards, I have a slide somewhere. Yes, okay. That would show us. This is only showing 3 of the 12 leads of an EKG. But you can see something that's really important that I want you to understand. Notice how these QRS complexes are all below the baseline. These are half and half, and these are all above. That's because of where the leads are placed. Each lead gives you a picture of a different angle of the heart. So you're gonna have QRS complexes in some places completely below, some that are half and half, and some that are completely above. Typically, we run rhythm strips in a lead that has our QRS complexes above the baseline. But if you see this and you're like, oh my God, what's wrong with that? Everything's upside down. It just means you're looking at a different lead than normal, okay? I don't want that to freak anybody out. We look at all 12 leads because it helps us see exactly where we're having issues with conductivity in the heart. Normally, with an EKG, we're evaluating the left side of the heart because it's the most important. Remember, it sends oxygenated blood to everywhere. We can do a right-sided EKG where we have leads that we wrap around the patient's back or place across the front, and that lets us look at the right side of the heart. We don't normally do that because when people have heart attacks, it's usually left-sided infarctions rather than right. Just know that that is possible to do. It is a thing. So if you see reference in a question to a right-sided EKG, that exists. It just means we're looking at the right side of the heart, the low pressure side, instead of the left side of the heart, the high pressure side. Good with that? Yes, no, speaking out for hold please. Yes. Okay. So you also have a basic EKG slideshow in your course. And we'll flip through and make sure that there's nothing that is super important that we missed with mine that I like. Okay. conduction system of the heart. I think this is a much more complicated picture than mine. Would you like me to post my, okay, all right, I'll do that for you. If you get anxious, like if somebody goes, boo, then, oops, then we've got the sympathetic nervous system that takes over and spikes your heart rate. So anxiety makes your heart go faster, okay? If you are an exerciser or you have certain medical conditions, your parasympathetic nervous system can slow your heart rate for you. This talks about how many beats per minute you get from things. We got that, we talked about that, we talked about that. Yep, covered that, yep. Here's a nice picture, lovely, of a 12 lead. And you can see how, looking from lead to lead, QRS is completely above the baseline, below, above, halfway, above, short, above, starting to trend to halfway, more or less halfway, and above. And you can see the square wave here, indicating that we did what?
Hit the button.
Cardioverted them. We gave them a shock. Lucky dog. Do you need to know where to place leads? Yes. That's a good thing. This is just a straight memorization type of issue. So if you've got 3 leads, top and bottom, you can place a whole lot of leads. All your B leads go across the chest. Not too hard to study on your own. This is a little more complicated than perhaps you need to know. Just know that the boxes are marked off so that you can count time. That's the reason that the paper is standardized for a rhythm strip. So you can look at it and count off exactly 6 seconds and then multiply by 10 to get a heart rate. Blah, 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 we already did that. Blah, we did that. Here's some other examples of artifact. See how that kind of looks like we've got something nasty going on? It's a little bit like it could be V-fib, right? It's all wibbly wobbly all over the place, but it's artifact. This is what it looks like when your patient has a sticker that's half attached and half not attached, like the adhesive is kind of giving way. So when it's actually touching the skin, you get something. As the patient moves and it pulls forward, you lose it. You can replace the leads as often as you need to. If you've got a patient who's very sweaty or very oily, then use an alcohol swab and scrub the area that you want to put a lead on before you put it on. And that makes it stick a lot tighter. Okay. That. Talked about that. You saw sinus braiding. You saw sinus tack. PACs is when we have a quick beat with a P wave that doesn't look exactly like the others. Do I think that you will be asked about this on your test for second level? I would not anticipate that. Look, it's our friend AFib, where we have the crazy chaotic baseline and our QRS complexes are randomly spaced. Recognize that? Yay. PVCs. Okay. So this is an isolated PVC. It's a big old funky beat. Here's another one too. It's a QRS complex that looks really different from all the others, and it's wider. It's a hiccup, essentially, of your heart. Are hiccups bad for you? They're annoying, not life-threatening. The issue is, if you have 2 in a row, we call them a couplet, if you have 3 or more in a row, we call it a short run of V-tach. Because with a PVC, you're not giving the heart a chance to push out as much blood as we need to. You don't need to know anything about bigeminity or trigeminity right now. So, here's another example of what V-tach can look like. Can you clearly recognize that this is something bad? This is a help situation. Everybody got that? Awesome. Another example of V-fib where it's just all squirrely, squibbly, like asking a kindergartner to draw a straight line. You get a lot of wobble in the mark. If your patient has a pacemaker, then you're going to see a little spike after your QRS complex that tells you where the pacemaker is fired. We just want to make sure that the pacemaker doesn't fire on the T wave. That's all we care about. And the doctor's in charge of adjusting the pacemaker so that we don't kill the patient by accident. And asystole still looks like asystole.
You didn't show a flutter.
No, we didn't show a flutter, and I can pull that up and show you that really quick since you brought it up. That's a regularly irregular rhythm. But since someone's interested, all the time. It's a prettier rhythm than atrial fibrillation. Let's see. Okay, this one's a defibrillation. Okay. So, notice that we have a lot of extra blobs, but they look the same. They kind of look like the teeth on a saw. So you've got your friendly QRS, and you've got spiky things, a P wave, QRS, spiky things, a P wave, QRS, spiky things, a P wave. And it looks very consistent except for the fact that there's all these lumps here that you're not supposed to have. This is what happens when your atria, instead of quivering, are kind of, instead of giving one nice squeeze, they, and that's what gives you all the extra lumps. But because it looks so consistent, that's why it's called a regularly irregular rhythm. It's irregular to have all the extra lumps, but everything else marches on the way it's supposed to. You cool with that? Wonderful. Let's talk about hypertension. The silent killer. It sounds so ominous, like some sort of terrible horror movie that you watch. Why do people get hypertension? What causes it? You could be genetically predisposed. Bad family to be born into.
High lipid profile.
Say again?
High lipid profile. High cholesterol.
Okay, if you have high cholesterol, that leads to hardening of the arteries. Then your arteries can't stretch and be elastic, and that will raise the pressure in the system. Smoking and stress.
Kidney disease.
Kidney disease. Diabetes can, because diabetes causes hardening of arteries as well, causes damage to the renal aldosterone system. It's a bad thing. Sometimes people have hypertension and we have no idea why. And that's called idiopathic hypertension. It's a fancy way of saying you don't know why your blood pressure is high. You could be pregnant and have pregnancy-induced hypertension.
Stressful.
Stress. Medications can cause hypertension as a side effect. So is it painful to have hypertension? No. Most people don't know that they have it. That's why it's the silent killer, because it doesn't make you feel bad. The worst that's going to happen is a headache for some people. That's the most common symptom of hypertension, is that you have kind of a pounding headache. So, bummer, man. Is it bad for you?
Yes.
Why?
Because
Can cause a stroke.
damages your blood vessels.
Damages your blood vessels. Once we have those hardened blood vessels, it means that we have to run the pump much more forcefully to get blood to the extremities. Because the vessels are meant to be elastic to expand and contract as needed to manage the flow of blood through the arteries. When the arteries stiffen and you need more blood to go to your feet, well, you can't expand the arteries. All you can do is just push the blood harder through the arteries. And that runs the risk of developing aneurysms. And those are bubbled or weak spots. Like if you get a bubble on the side of a tire and then it blows, that's an aneurysm. So hypertension can cause aneurysms in the brain, the aorta, the abdominal aorta, pretty much anywhere. And they're not a good thing anywhere that they occur. Very bad. What ethnicity is in the worst luck when it comes to hypertension?
African American.
African Americans, Native Americans have a little bad luck here too. What gender gets it worse?
Male.
Female.
Depends on who you ask. Males have the predominant amount of hypertension, but it tends to be more deadly in women. So, kind of do either way. So, they keep changing the number on what actually is hypertension. So, it's changed about 10 times since I went to nursing school. But JNC 7 says 140 over 90 is what we're going to officially call hypertension. There's talk that they're going to move it down to 135 over 90, although I think that's kind of over-egging it, but we're getting a little carried away here. What is systolic pressure? What's happening during systole?
Contractions.
Okay, that's ejection of blood. That's when things are pushing the hardest. So systole is when blood is being forced from the left ventricle out towards the end of the body. That's your highest pressure. It's the peak. What's diastole? That's rest. That's the lowest pressure that your heart and your blood vessels are under. So, which one is worse? To have a high systolic or a high diastolic pressure? Diastolic. We really want to focus on lowering diastolic pressures in patients. Because if your system is under a huge amount of pressure at rest, that's as good as it gets, that's what's likely to lead to weakening in the walls of the vessels and the development of aneurysms. So I get more upset about my patients when they have a high diastolic pressure than when they have a high systolic pressure. All right, so we can stage hypertension, all right, how high your numbers get. And you have this PowerPoint just like it is in the course shell already. Blood pressures are different based on how old you are. what's normal for children is not normal for adults. Want to make sure that with kids, if they have risk factors for heart disease, that we follow their blood pressure carefully. What would we consider to be risk factors for heart disease in children? Obesity is the number one. Diabetes is the number two. Sedentary lifestyle, poor eating habits. So these are things that are already setting up badness in motion for later life. We want them to eat a healthy diet, exercise, and get plenty of sleep. All right. Skip that. Skip that. Okay. The problem with high blood pressure is it damages your organs without you realizing. All of the pressure on your kidney starts to weaken the kidney itself, creates microfractures. We start to lose protein into the urine. Protein in the urine is never normal. So part of a routine screening for a patient with hypertension is a urinalysis. We will look for protein in the urine. And if they haven't had it before and they have it now, we know that we've got kidney damage that's occurred. The eyes develop problems with the retina. We start to blow the microvessels in the retina, and your patient begins to lose vision. The high pressure inside the brain leads to little berry aneurysms, tiny saccular aneurysms, and can cause a stroke when we pop one of those vessels. And peripheral vascular disease happens. Hardening the arteries in the lower legs means we get less circulation of oxygenated blood. We get tissue that starts to be anoxic. Tissue starts to die. Get the atrophied lower limbs. And that's bad for mobility as well as overall circulation. All right. Hypertension can be primary or secondary. Primary is you've just got high blood pressure and we're not really sure why. You got high blood pressure. Secondary, there's something making you have high blood pressure. A good example of that is pregnancy-induced hypertension. There is a specific cause making your blood pressure high, and we have to treat that cause. Make sense? Excellent. We can modify some factors, but not others. Can't modify your race or your gender, but you can modify whether you eat a lot of salt, whether you smoke, whether you don't exercise, whether you drink a lot. So we ask patients to work on the factors they can actively modify. How effective is that? Yeah, Brandon, it's not. It's not really. We tell patients what they need to do to lower their blood pressure, and 99 out of 100 nod and smile and say, yes, I'll work on that. Yes, I'll do it. Yes, I will. And they get busy and they get stressed, and it's not the top of the list because you don't actively feel horrible. The problem with diseases that don't make you feel bad in the moment is that they get pushed to the side. If you can't breathe, yeah, you're going to do something about that. That's something you feel. But the damage from hypertension is long-term, little bit at a time, and progressive. And patients just don't notice it happening. So, first thing we've got to do is to try to figure out why you're hypertensive. So we do a full history. We ask you questions that you may or may not be honest about. We look at what medicines you're taking. We do some lab work. We check your lipid panel. We check your chemistry. And we do an EKG. So, the right way to check blood pressure, which virtually never, ever happens. I find it amazing every time I get my blood pressure taken somewhere.
how wrong it is done. Your patient needs to be seated in a comfortable position, and they need to have their feet resting on the floor. You need to have your arm in a neutral position, the level of the heart. You need to check both arms. Why?
In case there's like a dialysis, or if they've had some kind of limb.
Okay, there can be issues on one side that changes the pressure on that limb. So people can have a pinched artery as part of thoracic outlet syndrome that's going to raise the pressure in that arm, or they can have lymphadenopathy after having stripping done that's going to change the blood pressure in that arm. We want to make sure that we compare the two. Sometimes people have a low pressure limb and a high pressure limb, and that's an issue. We need to figure out why there's a difference between the two. We need to check you for orthostatic hypotension. What does that mean?
Standing there.
We check you lying down, we sit you up, we check your blood pressure, we stand you up, we check your blood pressure. If your blood pressure is substantially different in the three positions, we got a problem. Diurnal blood pressure variability. What does that mean? Those are fancy, scary words. This is when we send you home with a blood pressure monitor that you wear for 24, 48, 36, 72 hours, however long. And it takes your blood pressure randomly during the day and during the night to see if your blood pressure is consistently high, or if you have peak periods of the day when your blood pressure is the highest or the lowest. When you take someone's blood pressure, if you follow the guidelines exactly, you should pump the cuff up first and listen until you hear the pulse go away. Deflate the cuff, wait, give it about a minute, inflate the cuff to about 40 beyond where you heard the pulse, and start slowly releasing the air, listening for the return of the sound of the pulse. And it should take about 2 minutes to take a blood pressure. Knowing those guidelines, how many of you have ever had your blood pressure taken according to specifications? Never. Never. It doesn't happen. I go to my doctor's office and his assistant is done in like 20 seconds. Okay, I know my blood pressure is fine because I check it myself, but still. This brings up a very important point, that if you're delegating vital signs to a tech, make sure that their technique is appropriate. They're not using a Dynamap. Be sure they actually can do it appropriately. And if you get a high reading from a Dynamap, what's the first thing you should do? You need to go take a manual pressure. You need to go make sure that that's an accurate reading. Do you see that done? Yeah. Half the time you can't find the equipment on the unit, so you can't do it even if you wanted to. White coat hypertension is, I love studies. There have been many, many studies that have shown that the idea that people are frightened in the doctor's office, so their blood pressure is elevated while they're there, is a myth. That when you give the same people an ambulatory blood pressure monitor for a few days, that they really do have elevated blood pressures. It's not just that they're scared of the doctor. So there's kind of no such thing as white coat hypertension, but some people will still say, my blood pressure is only high. So, to manage hypertension without medications, We want you to exercise, we want you to cut out salt, we want you to cut out alcohol, we want you to cut out smoking. We want you to manage your stress. So what stress management techniques would you suggest for patients? Yoga? Meditation? Are you familiar with tapping? This is a newer technique where you have a self-affirmation that you repeat to yourself, and you tap various pulse points on your body as part of a relaxation technique. So you can try tapping. You can try self-hypnosis. Sometimes that works for folks. You can try having them change the life situation that's giving them stress, like getting out of nursing school, this sort. The DASH diet, dietary approaches to stop hypertension. So this is an alternate food pyramid that's mostly based on fresh fruits, vegetables, whole meal grains, lean meats, very little oil, and almost no sweets. We want you to cut salt down to the bone. So on a DASH diet, patients really have to prepare almost everything from scratch, which means that most patients don't follow the DASH diet. What are you going to do? All you can do is educate them. You can't force anybody to do something. So then we end up with pills. All right, well, here's your pill, take your pill, you'll feel better. Initially, we can try starting with diuretic. If you pee out some of the volume, then your blood pressure will drop. If there's less fluid to move, then we don't have to push so hard to move it. We can use ACE inhibitors. Those make people cough sometimes, so we have to do a lot of teaching that if you start to develop a dry cough, let us know. Beta blockers, I love beta blockers, and calcium channel blockers. Beta blockers and calcium channel blockers both can make you constipated, but beta blockers also work really well for anxiety because they blunt the sympathetic nervous system. So if you have a patient whose hypertension is linked to lifestyle stress, a beta blocker would be a really good first choice medication for them. We start with low doses, we increase them gradually. Why don't we just jump in with, a nice hearty dose? If you lower your blood pressure too fast, you become symptomatic. You might pass out. Probably bad, right? Do you want somebody passing out on 75 as they're driving along because we gave them a full strength dose of beta blocker to start with? No, we don't want that. So we start low, we build up. We try to match the medications to the patient with what works for them with the fewest side effects. Sometimes we have to mix and match categories. So there's tons of medicines that you can use. And yes, I would look at the medication list and try to get comfortable with the categories at least before your test. Compliance is a big issue because people get tired of doing things, people get lazy about taking pills, people get lazy about cutting salt out of their diet. And this is not something we can cure, it's just something that we control. Hypertensive crisis or a hypertensive emergency. This is when you've got a blood pressure that's over 180 over 120, and this is actively making your organs scream inside your body. Ah, help me! So we have to lower the blood pressure right away. How do we do that? Do we give you a pill? Here's a bottle of labetalol. Come back and see me in a week.
No.
What should we do instead? IV. We're gonna give you something that's rapid in onset and that we can adjust the dosage of fairly quickly. So we can titrate it to get you to a blood pressure that we're happy with. Okay, great. Yes, ma'am.
Does your systolic and diastolic both have to meet those numbers, or is it like one?
If you've got one that's really impressive and the other not so much, we still consider it an emergency. Like, let's say you were 240 over 110. We'd still say it's a hypertensive emergency. Not good. Don't like it. Don't like it. Don't like it all. Don't like it at all. And to titrate blood pressure down, typically we put people either in step down or ICU. We can use nitroglycerin also to lower blood pressure. The goal with anything cardiac, if we have to start an IV medication to control something, is that we give you something that has a pill form so that we can wean you off the IV and onto the pill and you can go home with it. So that's our major hope, is we find something that works so that you can go home and keep taking it. So our goals are to reduce blood pressure by no more than a quarter in the first hour. Why don't we want to take you from 210 over 140 down to 130 over 64 right away? So you get rebound edema in the head, brain starts to swell, you can actually have a stroke from that. It's bad. So we want to lower it in a moderately rapid amount of time, but we don't want to go and make it happen like that. We want to stair step you down. Because if we take it down really fast, your body goes, oh, 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 and bad things start to happen. So the only time that we violate those rules are if somebody's having an ischemic stroke due to their blood pressure, or they're having an aortic dissection. So your aorta runs from here all the way down through the center of your body. And a dissection means that we've created a bubble where we've broken through one of the layers of muscular tissue and we're bulging outwards, and it can rupture at any time. So if it ruptures, you're probably gonna die. All that blood is just gonna pour out into your abdominal cavity and you're dead. So that's one of the few times that we will rapidly lower somebody's blood pressure. There are vasodilators that we can use that are very effective. Sodium nitroprusside, nipride is the name that it's called. Nicardipine, calcium channel blocker, and enalapril, nitroglycerin, spelled. We monitor vital signs continuously if we're doing a titration to lower pressure. So no more than 15 minutes between blood pressures. We would prefer that you have an art line that will give us a constant, immediate reading of what your blood pressure is in this situation. Okay. One thing that hasn't been on either of those PowerPoints that I want to leave you with for this week so that we can talk about it again next week, because it always confuses people, is the idea of preload and afterload. Did you look at that at all before class today?
No,
Yes,
but it was
no.
mentioned in our previews.
Recognize the words at all, or is it just a giant blurry mystery to you? Turn the lights back on. Okay. Because these are two really important things to grasp. Okay, everybody remember what preload is? Okay, so we can talk about it in several different ways. Preload is when your heart is at rest and it's going to be a wonderful, beautiful heart. We're just hanging out at rest, diastole, relax. Preload is how much blood is left over after we've squeezed out blood during systole. The other way to look at it is preload is the amount of stretch or the amount of pressure that fluid is putting on the walls of the ventricle. So knowing those two things, what would raise your preload? Say louder, guys.
The heart's not stretching too much,
Okay, if you have a very stiff heart, that could increase your preload. Time how?
Like your heart is at contracting between.
No worries. If you have very tight blood vessels so that more blood returns to the heart, that raises your preload. So anytime we use a vasoconstrictor, preload rises. If you have fluid volume overload, like a patient with CHF, that raises your preload because there's just more blood in the system. It's got to be somewhere. So those are things that raise preload. What are things that lower preload then? Come on, if it's not too much fluid, it's
Not enough.
not enough fluid. Dehydration and hemorrhage lower preload. Vasodilation lowers preload. If there's more room for the blood to be in blood vessels in the periphery, then there's less to hang out in the heart waiting for the next round. Does that make sense? It usually takes a week for folks to think about it and then really grasp it on week 2, so don't worry. Now let's talk about afterload. What is afterload?
The upper part of the heart, the atriums.
We're working with ventricles for afterload. If we want to get blood out of the left ventricle, what do we have to do?
Overcome the resistance.
Overcome the resistance. So we've got to be able to push hard enough to squeeze blood out of the left ventricle and into the aorta. So the more vasoconstricted the patient is, the tighter the blood vessels, the harder we have to push to make blood exit. Does that make sense? Vasoconstriction raises afterload. Vasodilation lowers afterload. If your vessels are loose and floppy and can hold a lot of fluid, then you don't have to push very hard to make it leave. But if your vessels are tight, the tubes are small, you've really got to force to make the blood go out of the heart and into circulation. Yes, ma'am.
Is that when it causes your like line sensation in your heart then?
Yes. An increased afterload for a long period of time causes the muscle of the heart to actually hypertrophy. So you get ventricular hypertrophy because of it. Another thing that raises afterload is if the valve itself, the aortic valve, is stenotic, it's gotten old and crusty and hard and doesn't open all the way. That makes it harder to push blood out through it. We need a nice wide open valve to push the blood out. So stenosis of the valve means it's harder to push blood through a narrow opening. And that's one of the reasons that we do valve replacements, is having high afterload puts a huge amount of strain on the left heart. And left ventricular hypertrophy is bad. It sounds like it wouldn't be such a bad thing to make this muscle stronger and bulk it up, but the problem is that as we bulk up this muscle and make it thicker and stronger, we have less space for the blood to be in. So the amount we can squeeze out goes down, which lowers our cardiac output. Cardiac output is stroke volume times heart rate. And when I have less room in my heart chamber for blood, my stroke volume goes down. See why I'm ending with this to let you puzzle it out for a week and come back and revisit it next time. It's truly not that horrible. I mean, it really is more straightforward than it seems, but at the end of 2.5 hours of listening to me yap, it does seem a little overwhelming. We'll work on it again next week. What questions do you have for me about what we've covered today? Are you just too lost to even know if you have a question?
Is there any way you can narrow down like the medications that like are really important that we really know? Just a lot.
I'll look at the list, but I'll be honest, the cardiac medications are all important because these are things that kill patients easily. And that's one of the reasons that you really need to know them, even as a new person. I'll